I think I am.
Oh, you are? Okay.
Unless, you know.
So I may just, before I may just say a few words, just to get it going before I get into this.
I'm gonna pay attention to what you're doing,
Yeah.
and as you're getting to certain places, I'm just gonna start to advance it as I see you hitting certain points.
Okay.
Right. And hopefully, I'll try not to move too fast. Try not to move too slow.
Yeah, all right.
I know your rhythm.
Yeah,
You
pretty
and me
much.
could dance.
I could, if I ad lib a little bit, then just slow it down.
Yeah.
Yeah.
Is this big enough for you?
Yeah, that's fine.
Okay, perfect.
Only the Perry Carney has to do a little disclaimer right before you.
Oh, before I go up?
She's
All right.
coming up.
All right, fine. Are you,
Seems like it. Where, me?
all right. How about we give her a round of applause? Come on. Nice going. So good afternoon, everybody. How's everybody doing today? Everybody's good? So welcome. I'm Bob Garrett, co-CEO at Hackensack Meridian Health. And it's, number one, I want to say it's always good to come back to Hackensack University Medical Center. It's home, and I'm glad to be back. And I actually have been here now 3 working days in a row, which is a new record, right, Ihor? Ihor's getting tired of seeing me. Friday, Monday, and Tuesday. Thank you. Thank you. But this is an important symposium today, and we appreciate everybody coming out for it. Obviously, the opioid crisis has not only been in the news, but has affected most of us in different ways, and certainly is something that's affecting our community deeply, our state, and actually our entire nation. So we wanted to get together today to bring forth some great speakers, some experts, people who are dealing with this crisis from very, very different perspectives, different angles. And I think you'll find today's symposium to be very useful and very, very informative. So first, officially, I'd like to welcome all of you to Hackensack University Medical Center. And I want to thank Dr. Ihor Sawchuk, who is the president of Hackensack University Medical Center, for hosting this event today. Ihor, thank you. We're honored to host this conference to bring together patients, parents, teachers, nurses, and key cabinet members in New Jersey and other officials to address the opioid epidemic. I'd like to especially thank our Health Commissioner, Sharif Elnahal. Dr. Elnahal, thank you for being here. Dr. Elnahal is on very little sleep. He just had a new baby boy. Congratulations to you. I told him I remembered those days like they were yesterday, but it was 25 years ago. But I didn't sleep for a couple months, so you look great. Welcome, and I'd also like to welcome Attorney General Gurbir Grewal. Attorney General, thank you for being here. Thank you both for your efforts to combat this scourge that has claimed too many lives and devastated too many families. I would also like to acknowledge, I don't know if he's arrived yet, but former Governor Jim McGreevey is scheduled to be here. And we're really proud at Hackensack Meridian Health to partner with the Governor McGreevey on the reentry program. And he's certainly been very, very involved in the opioid epidemic and behavioral health issues in general. I'd also like to extend a warm welcome to Bergen County Executive Jim Tedesco. Thank you for being here, County Executive. Bergen County Sheriff Michael Sodino. Michael, thank you for being here. Acting Bergen County Prosecutor Dennis Callow. And I don't know if I saw the Mayor of Hackensack yet, the City of Hackensack, John Labrosi. Is he here yet? He's coming, okay. Well, we're going to welcome him. Tell him I welcomed him, okay? All of these people that I'm introducing have really made a big difference and have addressed the opioid epidemic in their own way, in a very, very meaningful way. Commissioner Ellenhall, we know this problem is a top priority for the Health Department. Before returning to New Jersey, your work as a leader at the U.S. Department of Veterans Affairs led the way to improve practices to prevent opioid dependency. That's a mission that we share at Hackensack Meridian Health. We thank you for your leadership and are eager to partner with you to combat this crisis. Attorney General Grewal, thank you for making a difference on the front line as Bergen County prosecutor and now as our state's top law enforcement officer. As prosecutor, you led efforts to pair overdose victims with recovery specialists to give people a real shot at bettering their lives. By offering first-time offenders in Bergen County the option of treatment rather than prosecution, you have given addicts a second chance. We are privileged to have such a dedicated and innovative leader with us today. I'd also like to introduce our very own Dr. Michael Kelly, who serves as chairman of the Department of Orthopedic Surgery and Sports Medicine, and I think there's a few other titles too. Mike, did I forget a few? Yes. Mike has been with Hackensack University Medical Center and Hackensack Meridian Health for many years. He's also the chairman of the Department of Physical Medicine and Rehabilitation as well. Dr. Kelly, I want to personally thank you for your leadership in changing practices to reduce the amount of opioids patients receive, especially our student athletes. Your efforts have impacted countless lives and truly have improved health care in the state of New Jersey. Dr. Jerry Joseph is an inpatient psychiatrist and substance abuse specialist at Hackensack University Medical Center. Dr. Joseph and our physicians in behavioral health play a vital role in fighting this disease. We know that when we take a team-based approach, outcomes are better. Thanks, Dr. Joseph, for your outstanding contributions and your leadership. I will leave the details of to all of the experts that we're fortunate to have here today. But I do want to say at Hackensack Meridian Health, we are committed to improving lives by not only helping those struggling with addiction, but by working to prevent it as well. It is absolutely essential that we all join forces to work together. More than 64,000 Americans died of drug overdoses in 2016, double the rate from just a decade ago. And sadly, nearly 2,300 of our friends, neighbors, colleagues, and children right here in New Jersey died in the last year, a 35% increase in just 12 months. Only 4 other states had higher percentage increases in fatal overdoses. We are taking many steps at Hackensack Meridian to help our communities and to help our families. First, some of our hospitals have recovery specialists who connect with an addict at the bedside after an overdose. We know that more people battling substance abuse are getting into recovery because of this intervention, which is going on statewide now. At Riverview Medical Center, down in Red Bank, we employ a drug and alcohol counselor who works in the emergency department and throughout the hospital to refer patients with substance abuse problems for help. She sees 35 patients a week, and that number is growing. We are building a much more robust behavioral health system throughout our network. We are adding 37 inpatient beds to our 150 psychiatric bed capacity and maintaining robust psychiatric outpatient services at the same time. Additionally, we are starting a new psychiatry residency program this July with 10 physicians kicking off the 4-year program. A child psychiatry fellowship program is slated to start right behind it in the year 2020. And we recently announced a partnership with the Carrier Clinic, New Jersey's premier behavioral health provider. We will expand behavioral health services and build a world-class addiction treatment center in North Jersey later this year, right here in Bergen County. That way, people don't have to leave the state on the road to recovery without their family and their support systems. This effort that we're all engaged in truly takes an entire community, an entire state, and for that matter, an entire nation to be successful. And we at Hackensack Meridian Health are honored to help lead the way. We salute all of you on the front lines for your commitment and your tireless leadership. Together, we will save lives and give our communities greater hope. I thank you all for being here today. Now I would like to turn the conference and the podium over to Dr. Ihor Sawchuk, as I mentioned before, who is the president of Hackensack University Medical Center. Dr. Sawchuk has been at Hackensack for many years, has done a great job in various capacities as chairman of urology, our chief medical officer, and now our president at the hospital and at the medical center. And he has certainly been a passionate advocate for behavioral health. He has spoken, I've heard him speak before, on the opioid crisis, and I thank Dr. Sawchuk again for hosting today and for getting such a distinguished panel together for us today. Ladies and gentlemen, Dr. Ihor Sawchuk.
Thank you, Bob. It's great to have you here today with our influential panel to discuss this alarming health crisis. We thank you for your vision and for your leadership. And I agree, all of us must come together, healthcare, law enforcement, families, educators, to derail this devastating problem. I'm hard-pressed to think of any more urgent issue that is claiming so many lives, especially of those of our young people. We are honored today to have so many innovative leaders who have developed effective strategies to help our communities learn more about the dangers of opioids and to get help when the disease of addiction has taken hold. So let me introduce our first speaker, Dr. Michael Kelly, a genuine healer and a good friend. Michael and I did our surgical training 38 years ago, Michael.
I was going to say we're coming up to a nice reunion.
That's right, 38 years ago at St. Vincent's Medical Center in Manhattan. Dr. Kelly travels the country to lecture physicians, healthcare executives, and others about minimizing the use of opioids before, during, and after surgery to prevent addiction. He is also spearheading a program for personalizing pain management, including the use of genetic testing to determine which patients are most at risk for addiction. Please join me in welcoming Michael Kelly.
Thank you, sir. Thank you, Ihor, and good afternoon. It's a real pleasure for me, and Balpreet, thank you for the invitation to join this esteemed group. I've had the pleasure of being on the podium with the Attorney General recently at an open house, which was very exciting. I began this passion about 4 years ago. I was asked to give a lecture at a big orthopedic meeting down in Orlando, and it was called The Burden of Opioids. So I had to go do my duty, get our beautiful library here to help me out, pull all the data, and it was frightening because people like me were at the bottom of this whole thing. Physicians, oral surgeons, friends, we're all at the bottom of this thing. And it gave me a real desire to get to the bottom of this and see that we couldn't change things. 4 years ago, we stopped IV opioids on our orthopedic joint replacement service. And we've been working ever harder with our friends in pharmacology and pharmacy here to keep working on that. So with that, I'm going to try to set the stage for you a little bit on what we're really looking at here, give you a little bit of idea of the depth of this problem, a little bit of idea on the adverse effects, and then what we're going to do, we'll finish up a little bit to look at what we're doing here at Hackensack, trying to solve it, at least from this standpoint. First exposure to opioids is a take-home message tonight for everybody in the room. First exposure in the post-acute setting can set many people off on this terrible, terrible road. I was coming back from Dallas the other day from a meeting. My driver, who I've had for many years going to the airport, is telling me about a young man in his town, a little bit underprivileged, got a full scholarship. He's a quarterback to a very, very esteemed school in the United States. Just before, in summer practice, he hurts his shoulder. Unfortunately, he needs surgery. Post-operatively, he's given Percocet and more Percocet and later heroin. Now, he was very lucky. He got arrested and lost his scholarship, but not his life. But that's a story that goes over and over. I had a young lady, a friend of mine in Franklin Lakes, send me a little text the other night. Thank you, Michael, for working with opioids. It would have been my son Dylan's 29th birthday today, heroin addict. So you'll get an idea here in what we're trying to do. Recently, I was at the DEA meeting, and we looked at some of this public health epidemic, as Bob was talking about. Here's 2014 data, 47,000 drug overdoses, 1 every 10 minutes almost. 128 a day, almost half were related to opioid pain relievers. Now, some of this data is a little bit dated, but it doesn't come out in a timely fashion, so it's as good as we get. If we look at 2015, guess what? The curve is going from the lower left to the upper right, and it keeps happening. 55,000 drug overdoses, 1 every 9 minutes, 151 a day. Again, huge number related to opioids. In December, they gave me their preliminary numbers, and it increased to almost 60,000 deaths. It's a big number. Now look at New Jersey. Bob was just alluding to this. I got this from NJBiz, because the Bergen PAC, the FBI, and Lakeland Bank want to partner with Hackensack and try to get something in the school system. We have plenty about alcohol, but we don't have a lot about opioids. On record for a shattering pace, 6th leading cause of death in New Jersey. Already had over 700 or 800 deaths, 2,221 deaths in 2016, 85% related to opioids, and we're possibly on course for 3,000 this year if we annualize the present data. Pretty scary. We're out here lecturing, we're out here talking. The attorney's done an unbelievable job of saying that we can't, prosecute our way to success here. And instead, it's still getting worse. I was at a meeting in Florida in December. The prescriptions are decreasing and the deaths are going up. Probably due to fentanyl, probably due to the veterinary form of fentanyl, which is even worse. And the economic costs are not insignificant, both for this hospital and this entire country. Look at the CDC in 2015. Big numbers, almost $80 billion. And if you talk to the Council of Economic Advisors, that's not even close. They think it's 3% of GDP. And I was seeing recently where people are having trouble insuring their employees because the dependents are getting in trouble with opioids, and they're seeing a huge number there. Again, 2016, big numbers across the nation. Look at that number, $504 billion, and socially 17,000 deaths. So it's clearly something we should be here tonight to listen about because it's getting even greater. Now, just to give you a little idea on some of the geography here, look at this geography of the United States. Where those dots are, 12 states had more opioid prescriptions than people in the state in 2012, right? And so again, first lifetime exposure to opioids may be when they're prescribed a post-surgical pain pill, which I've been doing for 20 years. We have to manage pain, so we needed to learn to do it in other manners. But those are just some of the states, and I dare say that if we had a 2016 or 2018 map, those dots would be bigger and or smaller, but more spread out. Look at New Jersey. We're rising almost more than anybody. How do we get here? 70 million people per year are prescribed opioids. 1 in 15 will go on to long-term use or abuse. So this has been a rapid proliferation of users and people who are having trouble. Despite that, opioids had. I think it's becoming more minimal as a lot of the states have turned to limiting the prescriptions and the access, although that has its own problems. They remain the cornerstone of post-surgical pain. And it's a number of years now where drugs like hydrocodone were the most prescribed in this country, even in the Medicare population. This isn't just our children, our adolescents going to pill parties. I'll show you some data here that the people that I take care of between 45 and 65 were the highest frequency users. So as we look at tackling this problem here at Hackensack, it requires minimizing the opioids to prevent adverse drug events, and I'll show you just a little data there why that matters. We try to promote multimodal care. The pain doesn't go away. Successful management of pain is paramount for an orthopedist or many other different specialties to achieve good results and for the patient to be able to do their rehabilitation. And then one of the things that's very disheartening is to reduce the misuse, abuse, and what I didn't realize, the diversion. All those drugs sitting in your bathroom cabinets that are being utilized by people around the country. So let's look at trying to minimize adverse drug events. We're trying to decrease problems associated with economics at all hospitals around the country. Well, look here. If we look at opioid-related adverse drug events and look at the mean cost to the hospital, you can see here the difference. The red bar is when you don't have an adverse event. The blue bar is when you do. Pretty significant difference in terms of the cost. Very significant. If you look at length of stay, and we can very easily do the math on that, how that contributes to cost. Here again, almost double the length of stay when you have adverse drug events related to opioids. And our readmission rates. Well, orthopedics was really on top of the whole value thing because Medicare began to have us take care of their patients in hip and knee replacement in what's called bundles. So we're not only taking care of the patient, they stay here for 2 days and then they're off. No, we're responsible for the whole 90 days of care. So if you look at that readmission rate, whatever that number is for that, you can make that even double that for value-based medicine, which is where everything's going. So minimizing readmissions is paramount. And in minimizing opioids, you'll minimize readmissions. So let's look at why I'm talking about the short-term opioid therapy in the acute setting can give you trouble. You know, the first slide here is going to talk about a cervical spine study. So we know that spinal pain can be some of the worst. Neurologic pain is very severe, and we often have trouble managing it either preoperatively or postoperatively. But here you can see at 1 year post-op, almost 1/3 of these patients, following surgery to correct the problem of pain, were still on opioids. If we turn to the hand and the elbow and the wrist, which is, you would think is probably a little bit easier, this gives you one idea about diversion. How many people have been, I see on a Monday morning, softball, an idiot like me trying to play too much paddle tennis, comes in, this hurts. You say, did you take Advil or Tylenol? He said, no, my wife just had her wisdom teeth out and I got 90 pills sitting in the bathroom. So I took a couple perks and I got through the weekend. We hear about it all the time, right? So look at this study. Here's an upper extremity study. You had a number of patients. They were all given 30 pills, go home, and you only had to be in the study by saying you would call in at 6 weeks and say how many pills were left. 2/3 of the pills were left. 5,000 pills were sitting in medicine cabinets to be utilized. Most of the time, utilized properly in the future perhaps, but not being get rid of so that your daughter or son or somebody doesn't go ahead and use it. Two little things here, the patients who are getting joint replacements, again, they're not at risk for opioid dependence. And if you go and you talk to your patients, they'll tell you it was a hard time getting off the pills. But we usually have them off almost 2-3 weeks maybe now, not 2-3 months like we used to. And probably the most disappointing slide that I'll show you for me tonight, because I did nothing but encourage my kids to play athletics. Still at 66, I'm running around like an idiot playing athletics. Look at this data, it's frightening. Compared to non-athletes, adolescent males who participated in organized sports, this is a study from 3 years ago, 2 times the risk of being prescribed an opioid, 4 times the risk of misusing opioids to get high, 10 times the risk of medical misuse to taking too much. That's kind of freaky. Fortunately, my kids didn't have any injuries, so I'm lucky. How about the collateral damage? Suppose you're not even born yet, and your mom's an addict. Look at these numbers. Again, the slides are showing you increasing frequency. Addicted mothers having addicted babies, costs and social affairs are just terrible. You can see the numbers between 2010 and 2012 really taking a high upkick. It's a bad thing. Now, many of the states have done a good thing in looking at trying to how to figure out their prescription writing from at least those of us who are writing post-operative prescriptions for opioids, which is necessary from time to time, oral opioids. And here you can see they're based on this kind of study here, where you see the risk of the initial prescription episodes leads to the likelihood of long-term use. So if you look on the first slide, you'll see days of supply. So the more pills that are supplied, which equal more days supplied, equal an increased frequency of people still using these drugs at 1 and 3 years, and the same thing with the number of prescriptions per, say, a knee replacement. So the more prescriptions you get, again, increased use at 1 and 3 years. And finally, just if you look here, to let you know that it's not just our kids, the yellow line is 45 to 65. I've moved on to the next line at 66, but everybody's part of this thing. Every single person. And don't kid yourself, it's not just our kids. And this is probably something, I think we're all learning how to get rid of the pills now. I never really knew how to do it until I went around the country, different places. I think in Colorado, actually, one of the big things in an election was that they had vowed to have one of these places where you could drop off your drugs within, I don't know, maybe 3 miles of every person in the country, in the state, at different places. But you can certainly go to your local law enforcement areas. That's where we do it in Franklin Lakes, at least. So look here, this isn't drug. These aren't drug dealers. Not everybody ends up looking for heroin. Look at this. 68% of people using pain relievers non-medically obtain them from a friend or a relative. Frightening. So you need to think about what you're going to do with those unused pills. Fortunately, with the state regulations, you can't write for 90 pills anymore. And I think that's been a good thing. But we do have some people who need the pills, and when they can't get it, they sometimes turn to other things that are problematic. So again, we're not going to talk about heroin here, but it's very clear that many of these people start with opioids. Here you can see again the rising curves in deaths. 1 to opioids and heroines. 4 and 5 new heroin users started out misusing prescription painkillers. So we know the story. We've all heard it, I'm sure, in our counties. We see it on the front pages of the Bergen Record 2 years ago. And hopefully we're going to, by minimizing the first-time exposure, we can help contribute to minimizing this problem. So now, as we conclude, I'm just going to give you a few minutes on what we're trying to do here. Multimodal pain management is when you use 2 or more analgesics that work in different parts from where you have the problem. So let's say I did a knee surgery. Between the knee and the brain, it's going to try to work in several different areas with several different types of medications, with several different mechanisms, and each one of them cumulatively are going to try to give you the same relief as you got with overdoing opioids. And that's what we've been doing, us and many, many people around the country, to minimize pain and try to minimize the opioids we're using. As I said, I think the people who were really happy that we minimized and stopped almost using our IV opioids postoperatively were the nurses and the physical therapists, because nobody was throwing up anymore. Nobody was passing out because they were getting dizzy when they stood up. People were able to get out of bed the same day. We have 95% of these people up out of bed in a chair and or standing or walking because they're not drowning in opioids. So here you can see there's a number of different ways you can do it. Sometimes you can do local anesthesia. I'll go through this a little bit as what we're doing here. You can then do, you know that there's issues where you can have anesthesia related to your spine and then related to the central nervous system in the brain. So you can use multiple agents in different sites at different doses, all of which contribute to the cumulative effect of excellent pain relief, but very few with adverse drug events like we see with the opioids. And it's been very evident to us taking care of these. The way we used to do it is we'd start with weak opioids, we then go to more potent opioids, and then we give you any opioid we could find. And that just didn't work too well. And some people didn't come back for their second side if they needed because they would throw up or get so violently ill they were more scared of the pain management than they were the surgery. And here you can see now we're using, I always thought that Tylenol was just for my kids when they had a fever. But guess what? It's a pretty good drug. Although we like to sometimes use it intravenously, we call it intravenous acetaminophen, it's an outstanding drug. But guess what our drug industry is doing? Well, one, I think it's what, 25 cents for 2 tablets of Tylenol, maybe less, probably less. $23 or $4 for 1 dose of IV acetaminophen, same amount of relief, hopefully. They just bumped it up another $10 last week. We have an IV shortage in this country because of some of the problems in Puerto Rico. We're trying to minimize opioids, and now we're getting raped by the pharmaceutical people. It's a bad thing. It's a bad thing because we've been using a lot of it around here as we've tried to minimize opioids. But you can see here we're using a variety of different agents, anti-inflammatories like Celebrex. We use a lot of Tylenol, and we give you the medicine before you have the pain. We call it preemptive. Then during the surgery, we use some corticosteroids, which help reduce inflammation, and we use things locally. It's almost like getting when you go to the dentist and you get your Novocaine, but now it works for 36 to 48 hours. So it's helped us a lot with the pain. And then post-operatively, we begin the same. But we don't wait till you're either drowning in pain medicine or screaming in pain. We give it to you around the clock now. We've learned a little bit more. So you get your Tylenol, you get your anti-inflammatory, you get a little medicine to work on nerve pain. You maybe seen it, like something like Lyrica when you see the diabetic commercials on TV. And then we do give you some oral opioids if you need it. And then we have someone who's kind enough to call in 2 weeks and see how you're doing and making sure that you're not having trouble with your pain. It's called a navigator, to try to keep you out of trouble because we want you healthy during your post-operative recovery. And I think we're working on the data. We have now an opioid minimizing committee here, which pharmacy and myself share. And we're looking at every part of post-operative surgical pain management, trying to do similar things. Here you can see this is the way we do it now. And so we no longer do we use the IV opioids. And again, you may notice a lot of these different medicines that I've just described. And not only do we do it, everybody in our program does it the same way. The nurses understand it. The patients are educated in it preoperatively. They're educated, again, during their hospital stay. And we try to minimize, and we're blessed with people from pharmacy who help us pick out the right drugs and look at the data, go through what variety of different things, looking at the literature. So we try to get some standardization of things. We utilize now what we call nerve blocks. You may know them such as a spinal anesthesia. But sometimes you can block a nerve that only is a sensory nerve, so you beat the pain, but your muscles still work. And that's what we do in the knee here. So that helps minimize the pain, but you can still get out of bed and recover. We've been looking at, as I complete this talk, we're looking at a way to, when you look at people, roughly 20% of people can't metabolize morphine when we give it to them. They can metabolize through secondary pathways, the nausea and the vomiting, but they don't get any pain relief. And we can identify those people ahead of time. I think psychiatrists have been doing this in a lot of their medicines to see if you have the proper enzymatic makeup in your own genetics to be able to manage different medicines. We could take all the medicines I just showed you and tell you whether you're okay at metabolizing them normally, you metabolize them too slowly, or you metabolize them too fast. So say you were getting an anticoagulation medicine that makes you bleed and you're a hypermetabolizer, maybe you got a problem. So we can look at that ahead of time. And so we're trying to use behavior, genetics, and toxicology to look at this and come up with an idea. There are some validated surveys, simple little questions that we would hope to start giving to each of our patients preoperatively to get a little bit of an idea of who's at risk. Not perfect, but will certainly show us a way where we can get going. If we can get the genetic part underway, we could give you an idea what to do, and between the study and the genetics, we'll have an idea of definitely who's at risk and what kind of program to give them. Not one base fits all, but more personalized pain management, looking at different tracks based on your low, medium, and high risk of addiction. And then you would get a scorecard like this, which with the green and the red. Red means that you're not a metabolizer. That's a bad drug for you. Green means you are, and it's a good drug for you. And we can kind of have a score sheet for both anesthesia, pain management, and the orthopedic surgeons in order to take care of this. We're just beginning, so I don't have any data for you. This may be a little dream in my own mind, but we're personalizing everything. We're in the home of personalized medicine in the Cancer Center. Everything is personalized here as they're beginning to look at genetics, and every kind of therapy you get is based on you, not just your cancer. So hopefully we can do the same thing. So in closing, there's clearly an epidemic. I think we all wouldn't be here if we didn't understand that. It's not just a patient problem. It's for all of us, hospitals, physicians, insurers, business, communities, et cetera. I don't know if it's avoidable. I sure hope it is. I'm certainly going to continue my passion in trying to do this. We're hoping the state and federal legislation may be helping with these prescriptions, but time will tell. Thank you for your attention.
Thank you, Michael, for that excellent presentation. Our next speaker, Attorney General Gurbir Grewal, has distinguished himself as an exceptional leader. Mr. Grewal served as Chief of the Economic Crimes Unit in the U.S. Attorney's Office. As Bergen County Prosecutor, he launched innovative programs to collaborate with public health professionals, realizing that law enforcement alone could not address the opioid crisis. He launched Operation Helping Hand, the first time in New Jersey that people who were arrested for drug possession were offered treatment. His office also posted daily public alerts on overdoses throughout Bergen County, so communities and law enforcement had a true read on the escalating number of lives impacted by opioid addiction. Please join me in welcoming Attorney General Grewal.
Good evening, everyone. So, Dr. Sawchuk, thank you for the introduction, and thank you to Hackensack University Medical Center for having me. I'm very happy to be here. After 91 days as Attorney General, it's always nice to be at an event where I only have a 5-mile drive home as opposed to an 85-mile drive home from Trenton, and I'll be home for dinner tonight. And it's also really just an extreme honor to be back with friends from law enforcement here in Bergen County, from the Chiefs Association, from the Sheriff Saudino, our county executive, and Prosecutor Callow. It is not lost on me that I get to take the credit for all the programs that were just discussed by Dr. Sawchuk, but it was the collaboration by the law enforcement officers in this county, by the county executive, county health resources, the sheriff's office, so many others in this room that made those programs the successful programs that they were. So I want to thank them, and in particular the chiefs who are here. So thank you, chiefs. And I can't think of a more fitting topic for tonight's presentation: community, the front line in the opioid epidemic, prevention, recognition, and management. It's been mentioned several times already this afternoon that you can't arrest your way out of this problem. And as many of you in this room who are healthcare professionals know, the reason is because you can't arrest a disease. This is not a law enforcement issue, it's a public health issue that's going to require the type of collaboration that we see present in this room. The doctors who are on this stage, the law enforcement officers who are here, the nurses who are here, the parents who are here, whether you're affected as parents or not, it's going to require the collective response that we put together and put forward to put a dent in this epidemic. The numbers were thrown out by Dr. Kelly. I've seen some numbers that say in 2016, and there's a lot of data out there, but some numbers say that about 115 people a day were dying from opioids in 2016. The New Jersey numbers in 2016, we had 2,221 drug overdoses that were fatal, the majority of which were heroin and opioid related. The other numbers that we saw up there, 59 to 65,000 deaths in 2016 from drug overdoses. Again, the majority of which were heroin and opioid related. Now, if we want to put that in perspective, we've seen a lot of numbers put up there, but there are certain numbers that I like to compare that 2016 statistic to. If we look at the 20-year Vietnam War, 58,000 deaths. In 1 year alone in 2016, we lose up to 65,000 people. At the peak of car crash deaths in 1972, we lost 55,000 people. In 1 year alone, from drugs, 65,000 people. The peak of the HIV crisis, some 50,000 deaths. In 1 year alone, about 65,000 deaths from drugs. It's an unprecedented problem. And that's why it requires the unprecedented response that we see in this room. We have so many tools at the Attorney General's office. We had a lot of tools here in Bergen County, Mr. County Executive, but we have a lot of tools at the Attorney General's office. So what are we doing about it? The first thing I did when I got to the Attorney General's office is ask that question: what are we doing? We are 7,700 people at the Attorney General's office across 13 divisions, to include the Division of Criminal Justice, State Police, Juvenile Justice, so many other divisions that touch on this crisis. What are we doing? And what we quickly realized is that there is no coordination. There is no coordination among our department and among state government. And what's required is coordination. We have all these tools. And so what we stood up in the very first month that we were there was something called New Jersey Cares. It's the Office of the New Jersey Coordinator for Addiction Responses and Enforcement Strategies. And that office stood up within the Attorney General's office, is going to marshal all the resources that we have and then coordinate with our Health Commissioner and other state agencies, Department of Education. You know, when we were here in Bergen, we were here out on an island just trying to figure out how we could get into our schools. We had detectives going into schools to teach kids about drugs and overdoses and about the dangers and the pathways to addiction. Detectives who are not out there on the street arresting people, but instead, twice a day on Fridays, going in to teach kids about the different pathways to addiction. Our teachers need to help in this effort. Our school nurses need to help in this effort. And we have to work with our Department of Education to come up with a curriculum for middle school kids. And so that's one of the things that NJ Cares is doing with our Department of Education. But, you know, NJ Cares is new. We have been doing a lot. And so let me just give you a broad overview of what we've been doing in 3 different areas. What we've been doing as far as enforcement, and what we've been doing as far as prevention, and what we've been doing as far as treatment. Because those are really the 3 buckets of the law enforcement response. And a quick disclaimer, I'm not a doctor. These are the doctors, so I'm not going to be the medical guy here. I'll be the law enforcement guy who's trying to just get outside of his lane and outside of his comfort zone to really marshal together people. And that's the Bergen County model, and we hope to replicate it at the statewide level. As far as enforcement, we still have to arrest people. We have to be out there on the streets telling drug dealers that we know where they're selling drugs. We need to get the intelligence about how much those drugs are being sold for, what the stamps of heroin are, and who the dealers are. But we're being smarter about it. We're using data to target the dealers. We're not going after the low-level drug offenders. We're going after the dealers who are pushing fentanyl. We're going after the fentanyl mills. It's been touched on a little bit in the earlier presentations, but the real danger out there is the fentanyl, right? You have people addicted, and heroin is cheap, but fentanyl is cheaper. And so what people are doing, what drug dealers are doing, is they're cutting that heroin with fentanyl. In some cases, you'll see pure fentanyl out there. And the reason those numbers, despite our best efforts, are going up and up and up is because the drugs are getting stronger and stronger and stronger because they're being cut with cheap fentanyl that's often shipped into this country in mass quantities from overseas. And we can't intercept every package, but a few packages come in, they go to these fentanyl mills where they're cut with the heroin and they're pushed out onto the street. So we need to go after the fentanyl mills. And so that's one of our priorities, and we've been partnering with the DEA and other federal partners to focus our efforts, to use our data to focus on those fentanyl mills. The other piece of it, and my apologies to the doctors in advance, we're going after the bad doctors. We're going after these prescription mills. We have a robust prescription monitoring program in this state, one of the best. We're networked with 14 other states to collect data about prescribing. And so we had about 3 million inquiries into the PMP last year. We hope to get more, but we have all of our neighboring states and most of the Atlantic seaboard on the PMP. And so we're going to be out there encouraging our doctors to prevent patient shopping, but also to look at prescribing habits using that data. And we recently, based on data alone, prosecuted a doctor in South Jersey for indiscriminately prescribing opioids. That sends a strong deterrent message to physicians that they are part of this problem. Not all physicians, but those bad physicians who are indiscriminately prescribing drugs. So that's a little bit of what we're doing as far as enforcement. About prevention. Prevention has to include doctors. And Dr. Kelly talked about this, about the new prescribing regulations that would cut the 30-day prescriptions from opioids for acute pain, the initial prescription, to 5 days. But going along with that is an education requirement, that there has to be an education of the doctors themselves about the dangers of these drugs, but also of the patients, that sort of informed consent, that you need to tell them about alternatives. I think that's a key part of prevention. The other key part is what I mentioned earlier, is that we are going to go into the schools to talk to students. We are going to work with our Department of Education to come up with the curriculum to push out across the state to talk about the different paths to addiction. And I can't stress that enough, because we could talk about treatment, we could talk about arrest, and we could talk about making Narcan more available, but what we have to do is really focus on stopping people from getting on that path to addiction, because that's the only surefire way to avoid the crisis we're in and to really mitigate it. So that's going to be a key part of what we're doing. As far as treatment, there are a couple things. You know, one thing, and I neglected to mention this earlier, one thing those numbers don't capture, the numbers that Dr. Kelly shared and the numbers that I shared, they don't capture the Narcan saves, right? The use of naloxone, that overdose antidote. I mean, you could talk to the chiefs here. They go out daily sometimes. Their officers go out daily to the same house to revive the same person who's overdosed, multiple times a day. So Narcan is being deployed at unprecedented rates. In 2017, statewide, and I'm not capturing the ER numbers, we had 14,000 deployments by law enforcement and EMS personnel. Doesn't include the ERs. Doesn't include the parents who are able to buy naloxone or Narcan over the counter and save the life of a loved one. So that's a key part of our treatment. To have Narcan in the hands of these officers, to have Narcan in the hands of more people. And a lot of times when I speak at these events, I'll get a question afterwards. Aren't we just enabling people by making Narcan available to our cops? Don't they know that Tenafly PD carries Narcan, so they'll go use in Tenafly, or that Fort Lee has Narcan, so they'll go and use in Fort Lee? And my response is always the same. We just need to keep these people alive enough, long enough for them to get healthy. And so Narcan is a key part of our treatment efforts in this regard. The other piece in our treatment programs is what was alluded to earlier, Operation Helping Hand. You know, some might say that's an enforcement piece. It's enforcement. We get data about where drugs are being sold, but I like to call it a forced intervention, right? It's not really probably medically sound that you're not capturing people when they really want help. But when we're out there trying to go after the drug dealers and we run into the low-level drug offenders, we need to give them an option. You know, when I came into office in 2016 as a Bergen County prosecutor, I had to quickly get up to speed about the heroin epidemic. And one of the things I did is I read Steve Sterling's Heroin Town, which captured a terrific piece, captured a lot of data about the epidemic. But what I also did is I pulled old Bergen Record articles that predated me. And what I saw were these articles where you would have pictures of 200 low-level drug offenders who were arrested for simply buying drugs and bringing them back into Bergen County to use them. And I saw no sense in putting up pictures of 200 drug offenders, low-level drug users. We were naming and shaming them. And that just doesn't work. You're adding to the stigma. I neglected to mention this earlier, so I'll mention it now. On the prevention side, the other thing we're doing is if you go to njcares.gov, we are sharing in real time the data of overdoses, much like we were doing in Bergen County, but we are sharing the statewide numbers of overdoses, of Narcan saves, and of opioids prescribed. And you will see in a counter fashion at the top of that web page a summary of all those numbers with the last update date, and they're broken up by county. And the reason we're doing that is because we want all of you in this room and all of your friends to have conversations about this and to draw the stigma from it, so you know it's in Bergen County, you know it's in Ocean County, you know it's in Monmouth County, and if you go to the Bergen County Prosecutor's website, you'll see where exactly in this county it is. So if you're in Franklin Lakes and if you're in Ramsey, it is in your backyard. So you can't ignore it any longer, that it is a problem in each of your backyards, and you need to start having honest conversations with your kids about it, with your family members about it, and so we really want to draw that stigma. And I neglected to mention that earlier. Key part of prevention, to have that discussion amongst yourselves, to use that data that we're sharing with you. But getting back to treatment and enforcement, Operation Helping Hand. We sat down with the county executive, we sat down with the sheriff, we sat down with our chiefs, we sat down with our county health department, and we looked at all the resources that we had, much like we're doing with NJ Cares, to try to figure out what do we have here? What are all our tools? And we realized we had this incredible asset here in Bergen County, which at that time was Bergen Regional Medical Center, now Newbridge, with 80-plus detox beds. 80-plus detox beds right in our backyard. And so we said, instead of naming and shaming these folks in the paper, what if we, at that street-level interaction, gave these individuals a chance. And we said, hey, we know you're at a low point here. We have this option for you. If you come back, when we get back to our office, we could talk to you about it a little bit more. But if you need detox, we have a detox bed for you tonight. If you need inpatient treatment, we have that lined up for you. If you need outpatient, we have that lined up for you. And we brought together incredible people, just incredibly committed, including recovery specialists, individuals who were clean for 3 or more years, who were there sitting, talking to these folks and saying, hey, I was where you were, and if somebody had given me this opportunity, I would have jumped on it. And we achieved incredible successes. We've had, I think, 3 operations now in Bergen County, and on average, you would arrest 40 or so individuals, and more than half would take you up on it. And the numbers are dramatic. After 6 months, you still have 10, 13 people still in some form of treatment. And those numbers are really better than what you see when people go in on their own, because it's a law enforcement intervention. I think there's that fear of law enforcement. I also think that the recovery specialists are incredible, incredible people who stay on top of folks to make sure that they remain in some form of treatment. So what we hope to do at the statewide level is replicate this across the state. And in June, we'll be doing it in about 6 other counties. And my hope is that if we track that data, that we could achieve similar successes in other counties, that we could roll it statewide and just have another avenue to have people get into treatment. The final piece, the final 2 pieces, and my friend Joe Coronado is here from Ocean County, the Ocean County prosecutor. Anything I know and do well when it comes to addiction and law enforcement comes from this gentleman. He has been at the tip of the spear, at the forefront of the fight in Ocean County, and we have all borrowed, stolen, and taken great ideas from Joe Coronado, so we should recognize him this evening. And one of the first ideas I took before we went into Operation Helping Hand was what we ended up calling the HEART program, the Heroin Addiction Recovery Team, where we offer walk-in hours at some of our police departments. If individuals who are suffering want to come in and turn paraphernalia, if they want to get married up to a treatment service, and that's working. And that's a program that Joe started in Ocean County. We have it in 3 towns in Bergen, in Lyndhurst, Paramus, and Mahwah. And my hope is to make that available in more towns across the state and offer that option as well. And the final piece of all of this, I knew I should have written some notes. I did write some notes. The final piece of this on the treatment side is the recovery specialist. It was alluded to earlier by a number of the speakers. In Bergen, what we did is every time there was a Narcan save by law enforcement in this county, they notified our operations center, the PSOC up in Mahwah, and we had recovery specialists deployed to that ER, wherever the save happened. So if it happened in one of the towns, Fort Lee, for example, and if they were bringing that individual to Holy Name or to Englewood, they would let the PSOC know, and at the same time, we had a list of recovery specialists, volunteers on call, who would then deploy to that ER setting and then have that forced intervention and try to get that person into treatment. Because as you all know, once people are medically cleared, they're on their way. And if they're on their way without any options, it's sure enough going to lead to the next overdose and perhaps next overdose fatality. And so that's our hope, that we have another way to break that cycle of overdose and prevent that next Narcan save, prevent that next fatality, and get people into treatment. So again, I am thrilled to be back in Bergen County to talk about the wonderful programs that we launched here in Bergen County and then hope to replicate statewide. And I am so thankful for each of you for being in this room. We're gonna beat this thing, not because we have no choice but to beat it, but because all of you in this room, all of us have made the choice to beat it. And I'm hopeful. Thank you.
Thank you, Attorney General. Before we go on to our next speaker, I'd like to welcome and recognize a couple of individuals. Governor Jim McGreevey. Governor, where are you? Welcome. Thank you for being here today. And I'd also like to welcome Don Parker, CEO of the Carrier Clinic. Don, welcome. So our next speaker is our Health Commissioner, Dr. Sharif El-Nahal, who comes to us from the United States Department of Veteran Affairs, where he spearheaded efforts to improve quality and safety in the delivery of health care to our nation's veterans. The agency has made real strides in reducing opioids in the treatment of veterans. Dr. El-Nahal was appointed to the VA by President Obama as a White House Fellow in 2015. In this capacity, he founded the Diffusion of Excellence Initiative, which helped the VA establish consistency in clinical and administrative operations across the nation. Dr. El-Nahal received his medical degree and MBA with distinction from Harvard University. He trained at Brigham and Women's Children's Hospital and Johns Hopkins University. A native of Linwood, we are glad he has returned home to New Jersey. Please join me in welcoming our Health Commissioner.
I just want to thank Dr. Sawchuk and, of course, all of the Hackensack Meridian leadership for inviting me here to speak to you today, and, of course, the other members of the panel who really set up this discussion well. We are going to proceed, as the Attorney General alluded to, with a comprehensive public health approach to this problem. And I think up to this point, as he also mentioned, there's really been a striking lack of coordination with the efforts that have gone on across state government that have not allowed for institutions like this, for municipalities, for counties, to be able to leverage the resources and the scalable benefits that we can provide as a state. So all of that is changing, and I hope I can convince you of that by the end of my presentation. Where should I point it? Oh, this one. That's the laser.
Point it at the sheriff.
All right. Oh, did I just turn it off? Oh, no problem. If I touch it, I'll break it.
Okay, I'm just gonna go like this. Oh, what do we do here? There we go.
Oh, great. There we go. Thank you so much. All right. So I'm going to present the public health priorities, all of them, to make a point. Obviously, we have the goal of eradicating the opioid epidemic, as the Attorney General mentioned, as a main pillar of one of our public health priorities. But really, mental health and addiction treatment underlie all of our priorities in public health. We know this problem is not isolated. It seeps into the other issues I'll describe. Increasing health coverage and lowering costs, out-of-pocket costs for people, will allow them to access the care they need if they're in a state of addiction or have a mental health condition that leads to addiction. Enhancing access to and quality of mental health care. The comorbidities of mental health and addiction, as well as a lot of primary care and behavioral health and allopathic diseases, really necessitate the integrated care and the importance of really combining addiction treatment with all of these other issues. Improving and expanding on the medicinal marijuana program. I will try to convince you today that this will be a major tool that we have in preventing that initial opioid exposure that Dr. Kelly eloquently described, and how we can really reduce that with this important tool. Decreasing maternal mortality and improving access to reproductive care. Neonatal abstinence syndrome, if you ever seen that as a clinician or as a parent or as a family member, you will never forget it. It has striking effects on the child, and of course, it has effects on the likelihood of that child surviving in their first year, and of course, on all of the other issues that affect the mother. And then finally, reducing disparities in public health outcomes. This problem has existed in our cities for a very long time, long before it made headlines, and has affected vulnerable communities for years before it started to expand into other communities to the scale that it is now. And so this is a problem, of course, that affects all of us, but really started in our most vulnerable communities. Foundationally, what is enabling us to accomplish progress in these priorities. Interoperability, the seamless sharing of healthcare information from institution to institution. You've seen statistics from 2016 that are definitive today. It's 2018. The reason you're not seeing 2017 yet, or data from last month, is that we do not have efficient and effective ways of collecting data at the point of care and presenting it. And this primarily benefits the patient to be able to go from emergency room to emergency room or clinic to clinic, hospital to hospital, and not have to go through all sorts of hoops simply to have their healthcare providers have access to their health information. So interoperability of health information, in other words, making it accessible regardless of the doors that somebody walks into for treatment, will be a major enabler, and will also enable our public health efforts by making data accessible and easy to interpret and analyze with our public health efforts. And then finally, foundationally, innovation and value-based care will be the pillar for what will advance all of our efforts. We will not make quick progress in any of these ambitious healthcare priorities unless we really take advantage of our entrepreneurial community. We bring folks who are able to make apps, for example, that can seamlessly transfer someone's health information from place to place, really transfer ownership of their health information to themselves. All of that will enable progress, especially on this issue, and I'll describe how. So just quickly highlighting this as a unique public health priority. The governor has prioritized this public health goal, $100 million in his proposed fiscal year 19 budget. And this is not money that will go to one department or for one purpose or to one area of the state. It is divided purposefully and with the thought of really making a coordinated system. $56 million will go to prevention, treatment, and recovery. That will span to things like alternative treatments to opioids, techniques like Dr. Kelly described, spreading best practices, to medicinal marijuana, to treatment, and to recovery. All of those programs will be covered in some respect by this portion of the money. Social risk factors, providing social stability to folks who are addicted or who are at risk of becoming addicted will prevent addiction better than anything else. Housing, supportive services, all of these social determinants will be addressed with that portion of the money. And then $13 million in infrastructure and data. I just described how an interoperable network of health information, combined with all of the state-level data that we can tag to individuals, will allow us to know how much progress we're making and how quickly in this issue. We're convening the entire state government, essentially, who have a role in this issue, as well as stakeholders in the community, in a summit that we're doing on June 5th. It's called Better Together. This is just one example of many about how we're really trying to coordinate our efforts and advance a single strategy that will make progress. So how are we organizing this in a true, rigorous public health fashion? We're really starting with the primary stakeholder here, which is the person going through the journey addiction. It starts with prevention. Not allowing somebody to have that initial exposure to opioids, whether it's through an opioid prescription, which is the case now 80% of the time for folks who end up becoming addicted, or through illegal drugs. What can we do from a social standpoint, from a programmatic standpoint, at all levels of government in the state, as well as in our hospitals and clinics, to prevent? And the entire idea is each X here on this chart is a door that we want less and less people to go through in that journey. The next door is the addiction door. So you can be exposed to that prescription. Hopefully, if you are, clinical best practices are followed, for example, such that you will not become addicted and you can get off the medication safely. If you cross into the door of addiction, that gets into the whole slew of best practices that we have for you on treatment. And so that is treatment in our behavioral health clinics and addiction clinics. It is treatment in our prisons. It is treatment for folks going into reentry, and it's people who are in our psychiatric hospitals who are not yet getting medication-assisted treatment, even though they're in the hospital for a mental health reason. We are going to change that, and we're going to go through an expansive set of best practices in treatment. we have what is then the cycle of recovery and relapse. The realistic goal for someone who's passed through door 2 is to extend the length of time between relapses until you have extended drug-free periods. And that is what we are focusing on. It's going to be evidence-based, treatment, recovery, and then in the situations where somebody overdoses, making sure our first responders have that dose of Narcan to give to people when they find them. So all of this is to say that not one solution is going to work. We need to have solutions at every layer of this, in prevention, early intervention, treatment, recovery, and emergency care, such that more of the care will move to the left side of this chart. And hopefully by the end of our experience with this, when we're really making progress, we're doing much more prevention and early intervention than we are giving doses of Narcan on the streets. I'll first talk about some things we're doing in prevention. So I had to bring this up because I was going to be the only one to do it on this panel. We are extensively expanding the medicinal marijuana program. It will be one of the tools in clinicians' toolboxes, if we do this right, that will prevent that initial opioid prescription if it is not needed. It will be on that bottom or perhaps middle tier of the tiers that Dr. Kelly described before we get to the top when you actually have to prescribe opioids. And we've seen evidence that this has worked. Unfortunately, because marijuana is still a Schedule I drug, it is difficult to do actually impossible to do clinical trials essentially, because you cannot get NIH funding or some of the big buckets of funding to do that research. However, you have observational studies, cross-sectional looks about how states have done with medicinal marijuana programs correlated with initial opioid prescribing. So we know from a study that just came out about a month ago, or even less, that 5.88% lower rate of opioid prescribing exists in states that have had legalized medicinal marijuana versus states that do not. We also have almost 4 million fewer daily doses filled of those prescriptions. This study was a big deal because before, all we had was the final outcome. We knew that we had a 24.8% lower mean annual opioid overdose mortality rate in those states that had legalized medicinal marijuana. But we couldn't exactly point to the medicinal marijuana itself as causal. While this doesn't say it's causal definitively, it at least proves that the causal pathway is there. You are seeing less opioid prescriptions in those states that have medicinal marijuana programs, which means that clinicians are likely replacing that as an option versus opioids. And that is exactly what we want to see. And so you have to ask, why are we expanding the program? Is there proof that actually expansion of these programs and making it available to more clinicians and more patients is moving the needle even further? And I will say yes. The same study that was published by Bradford and colleagues in JAMA showed that there is a year upon year incremental lowering of opioid prescriptions with states that have legalized the program. And so year on year, these states have expanded their program. We are doing a step function of increasing the program size and scope and the number of conditions that it will be used for. Most notably, we are now making it available for treatment of chronic pain, both from visceral origin and from musculoskeletal origin. So that case that Dr. Kelly described of somebody coming in with shoulder pain or somebody coming in with a musculoskeletal issue, or somebody maybe even post-operatively, depending on people's comfort with this as we go forward, will ultimately have an effect and lower that initial opioid exposure. Moving along in the journey to early intervention. The Department of Public Health, is doing a statewide neonatal abstinence syndrome public health campaign, an awareness campaign that is making pregnant women who are addicted to opioids aware of the options before them. Unfortunately, the trends in this problem are not looking good. New Jersey has doubled the number of NAS cases to 685 babies diagnosed in 2016 versus 2008. This is corresponding to the skyrocketing overall rates of addiction. So unfortunately, pregnant women are not spared from this trend. And obviously that affects the fetus. The fetus is exposed to opioids in the womb, becomes essentially addicted to the opioids themselves, and when they give birth, 2 or 3 days later, they go through withdrawal. And seeing an infant go through that and all of the risks that poses to their development and their ability to thrive is striking. And so we are making sure that all of the resources available to mothers who may have just given birth, or especially pregnant women before they give birth, again, is an example of earlier intervention that will hopefully impact not only the child but the mother and get her into treatment. Moving along to treatment, I want to focus on something that has actually allowed states to turn around their trends. Unfortunately, in New Jersey, the Attorney General just reported recently that we may actually exceed the 3,000 threshold of deaths this year, which would be staggering. We have over 2,200 deaths in 2016. Unfortunately, we're still compiling 2017 data. But we're seeing an upward increase. Some states have actually begun to turn that around. And so the states that have actually been able to do this have focused on key initiatives that target very high-risk populations. When somebody is sent to prison, and if they're addicted to opioids, they go through a process of detoxification. And however long they're in there, when they are released, they cannot possibly be exposed to the same dose of opioids that they were taking through heroin or through fentanyl, which is hundreds of times the dose of heroin and other opioids, without having a much more strikingly terrible reaction. And that is why the post-incarceration death rates from opioids are so high. There's a physiologic reason and there's a social reason. 129 times the likelihood of dying from overdose in the 2 weeks following release versus the general population. Very staggering. Obviously, this is a population on which we should be focusing. We already have a pilot program on this. It is not providing treatment behind the wall, as they say, but it is allowing folks to go out of the Atlantic County Jail with the right security to be able to get medication-assisted treatment and go back into behind the wall again. It began in August of 2017. There's 204 people treated to date. That is just the beginning of what's possible. I will give the example of just one state that has done this right. You have West Virginia. You have others focusing on this that have made big turnarounds. In Rhode Island, the Department of Corrections, it was the first state to offer a broad range of therapies, all 3 forms of medication-assisted treatment, to their inmates. Inmates can take methadone, buprenorphine for up to a year, and then about a month or 2 before they're released, they're given Vivitrol. The mechanism of that helps to, it makes sense why that's the last one given before they leave. And so it is a comprehensive treatment. It's not just the MAT, it's also counseling, which is the standard of care. You really shouldn't be providing these drugs without the associated behavioral health care. They do that, and then importantly, they focus on reentry, and this continues after their release. And so you're not leaving folks hanging when they're discharged. You're connecting them to community services and ensuring their treatment continues. The numbers for this are staggering. A 65% decrease in opioid overdose deaths from this population reentering society, just in 1 year. First 6 months of 2016 versus first 6 months of 2017. They compared it to the folks that have not been incarcerated, and unfortunately you only saw about a 3% decrease in that population. So all of the other public health efforts that Rhode Island was undertaking for folks who didn't actually hit the correctional system had that effect, and because they focused on that population, an overall 12% decrease in just 1 year in their overdose deaths. Imagine the potential here in New Jersey, where you have that much higher of a rate of opioid overdose deaths in this vulnerable population, and what we could do with reentry with folks after they are discharged. So again, these are just some examples of how we're starting to fill this comprehensive public health approach. We are plugging in the best practices in each of the categories: prevention, early intervention, treatment, recovery, and emergency care. Figuring out what has worked in other states, figuring out where there is evidence, like the research studies that I showed you, and really plugging in with an evidence-based approach, making that $100 million put to good use, where we can get a real return on investment to taxpayers. And then finally, the other piece of a public health approach is to target geographically where our biggest problems are. This is a map that I had my team make that overlaid the 2016 death rates. So the more red you are in this map, the higher the absolute death rates in your county. So we're talking about Ocean County, Atlantic County, and some in the north as well. And then overlaying that upon the data that shows the increase, the rate of increase of people dying from opioid overdose deaths. That is the diagonals. If you're a diagonal in this map, it's not good. So it's really allowing us to focus on where we can make the most progress. It's no secret why we have our current pilot in Atlantic County for MAT within prisons. We are focusing on where this is being hit the hardest. So again, we have at least an initial moving of the needle on this issue. But again, we are going to tackle where this is happening, which is really in almost every community in the state. Ultimately, when we finish this up, we're going to have to do prevention. We're going to have to do early intervention in every place. And then the more initial efforts, of course, in places that are hit the hardest. So thank you. Please follow our campaigns on social media and awareness for this issue. We're going to be publishing a lot on this. I really appreciate the time. Thank you very much.
Thank you, Commissioner. Our next speaker is truly on the front lines of the opioid crisis, Dr. Jerry Joseph. Dr. Joseph joined Hackensack University Medical Center last year and serves as an attending psychiatrist with a concentration in addiction psychiatry. He provides education and clinical supervision to psychiatry residents and medical students. As we learn more about this devastating opioid addiction, it's imperative to have compassionate and caring experts such as Dr. Joseph integrated into the treatment plan at our medical center. Please join me in welcoming Dr. Joseph.
Hi, everyone. It's an absolute pleasure for me to be here speaking in front of you and with this esteemed panel. I'm especially proud because I was born and raised not in Olean, New Jersey, but in Bergen County, and it's been a dream of mine to give back to the community. So we're going to have a discussion on opioid use disorders. First, I have no disclosures. We're going to get into where heroin came from, its origins. What you're looking at here is the opium poppy. That white sappy material is opium. This is the first opiate cultivated, and it dates back to pre-3500 BC in terms of its use. It's been documented being used in ancient Mesopotamia amongst the ancient Egyptians and Persians as well, for both medicinal and illicit purposes. In 1805, morphine and codeine were isolated from opium. Morphine was initially actually used to treat opium addiction. However, what they did not know at that point is that morphine had about a 10 times more potent euphoric effect when compared to opium. And this is where morphine misuse and abuse kind of began. Fast forward to 1874, a chemist by the name of C.R. Adler Wright at St. Mary's Hospital in London experimented with morphine and various acids. He created diamorphine or diacetylmorphine. This is the chemical name for heroin. From this invention, nothing came of it initially. Go ahead another couple decades, and another chemist by the name of Felix Hoffmann, who worked for Bayer Pharmaceutical in Germany, independently resynthesized diacetylmorphine as well. And it was found out to, at that point, to be more potent than morphine, on the order of 1.5 to 2 times more potent. So what Bayer did at that point was they reputedly coined the drug heroin after the German word heroisch, which means heroic or strong. And at that point, Bayer led the commercialization of heroin. Here's an ad from the early 1900s promoting heroin as a cough suppressant in cough lozenges and other things. It was even used on infants to treat teething. Heroin is ingrained in our culture, particularly our pop culture. It's something that is at times, unfortunately, glorified, sex, drugs, rock and roll, etc. So I wanted to touch base on that as well. Several notable people in pop culture have struggled with substance use issues. Robert Downey Jr., Iron Man, well-documented issues with substance use, including heroin. Kurt Cobain, popular musician, he committed suicide with high concentrations of heroin in his system. More recently, Prince, he passed away and toxicology found elevated levels of propofol and opiates in his system. Not on this list also Whitney Houston, who passed away with elevated levels of both cocaine and heroin in her system. So how do opiates work and how do we get so addicted to them? Heroin specifically, when taken by mouth, undergoes extensive first-pass metabolism. Therefore, it's broken down into a prodrug for the systemic delivery of morphine. However, if you can bypass this first-pass mechanism by using parenteral routes, injecting, sniffing, etc., that first-pass metabolism does not occur. The acetyl groups stay on, making it more fat-soluble. This is important because it crosses the blood-brain barrier that much quickly. Once in the brain, it's broken down into its constituent components, tags onto our mu-opioid receptors, and triggers our reward system. It results in copious release of dopamine, and that's what kind of causes the euphoria or the typical heroin high that people are always chasing. Another interesting fact about heroin is that on our mast cells, there are mu-opioid receptors as well. So sometimes you hear people who are taking opiates or using heroin complain of itching or pruritus. This is due to a massive release of histamine from within our mast cells. And people continue to use the heroin even though they have this adverse effect. There are various routes of administration when it comes to heroin. And I want to touch base on this because as the purity of heroin has increased over the years, the intravenous route is no longer needed to get that high. Heroin now is cut with much more potent synthesized opiates that we touched base on, fentanyl, and now even cases are coming up in New Jersey with carfentanil, which is essentially a horse tranquilizer. So, data put out by the DEA, the TED study in 2005, I believe, shows that intravenous use is popular, but other routes of administration are highly becoming more popular, such as snorting or smoking. This takes away the stigma of using intravenously and allows people to kind of rationalize their use. Here on the right, we see typical paraphernalia you might want to look out for people who are using IV heroin: lighters, little baggies, spoons, syringes. On the right, you see a young lady smoking heroin with tin foil and kind of like a jerry-rigged smoking pipe. Lesser known routes of administration: skin popping. This is where an individual, if they can't get a vein for whatever reason, injects heroin subcutaneously into the fatty layer of the skin to potentiate the same exact high. A lesser known route of administration is plugging. Essentially, they create a suppository and inject it into the rectal or anal cavity. So opioid overdoses, that's why we're here, right? And I mentioned, as these routes become more popular, it's because the purity of the heroin has become more popular. Or not more popular, but more elevated. They're also being cut with things like fentanyl and carfentanil. This chart here shows the relative strength that I'm talking about. If you look in the middle of the graph, we see heroin highlighted in blue. Heroin is somewhere on the order of 5 to 8 times more potent than morphine. Move down that graph to the right, and you see fentanyl. Fentanyl is on the order of 100 times more potent than morphine. Move all the way to the right and you see carfentanil. Carfentanil is on the order of 100,000 times more potent than morphine. So when things are being cut with these things, we're at increased risk for accidental overdose. Here, as a result, we've had an increase in accidental overdoses, and this data is data from between 2014 to 2016 of the counties that were most hardly afflicted by the opioid overdose and the opioid deaths. Atlantic, Cape May, Cumberland, and Ocean County. And it shows continued incremental increases in opioid overdose deaths. So what are some strategies to address overdose? This is a very important slide. We touched base on some of it. Increased access to naloxone, or Narcan. First responders, police, EMS, etc., have access and have been trained to utilize naloxone, saving countless lives. People who are getting certified for CPR and basic life support are now educated about naloxone and Narcan overdose kits. Legislation has been passed where now an individual can walk into a pharmacy and not need a prescription to get naloxone. Private pharmacies across the country, including CVS and Walgreens, have made it an initiative to have naloxone stocked behind their shelves for people coming in to look for it. There's been passage of Good Samaritan laws here in New Jersey and across the country. These laws provide some sort of protection to individuals who witness an overdose. A lot of times overdoses are witnessed, however, the individuals who are there are either A, high themselves, B, carrying drugs, C, have warrants, or whatever else, and they're reluctant to activate EMS. Good Samaritan laws provide them a certain level of protection for doing the right thing, essentially, and saving a life. There's been expansion of the prescription monitoring system. In New Jersey, that's the NJPMP, where we can look up our patients and see if they're being prescribed opioids or other controlled substances, and kind of see if they're doctor shopping or if there's any suspicion of deviant behavior. Prescription take-back events. They're very popular across the country and municipalities across New Jersey. They typically occur at our local police stations, town halls, and at local hospitals as well. There's been talks about supervised injection facilities, which there's some data on, where people can go to essentially a safe place to inject, have clean needles and things of that nature as to reduce harm, essentially, and to monitor them in case they do overdose. Finally, the big thing is the expansion of opioid agonist treatment, and this is what I'm going to touch on a bit more. The evidence-based approach to heroin addiction. First, we have methadone maintenance treatment. And again, these are all a harm reduction technique where we look to minimize harmful effects to patients afflicted by addiction. Methadone is a form of opioid replacement therapy that reduces or eliminates the use of illicit opiates. It helps reduce the criminality associated with opiate use and allows patients to improve their personal health and be more productive in society. Methadone also allows people to minimize their exposure to potentially harmful diseases and transmittable diseases such as HIV and hepatitis. The principal effect of methadone is to relieve narcotic cravings, suppress the abstinence syndrome, and to block the euphoric effects associated with opiates. Methadone has been and can be administered safely and in a non-sedating manner to help individuals who are in need. It has also been the gold standard for quite some time in treating pregnant women who are addicted to opiates. For those individuals who might not necessarily want to be on agonist treatment for a long period of time, there's opiate or methadone or Suboxone reduction programs. This occurs when a patient decides to go on methadone or buprenorphine. It's titrated up to a dose where they're stable, where they're no longer having cravings, where they're no longer having physiologic withdrawal. And once they're stable, both physically and psychologically, it's titrated down with the appropriate psychosocial services in place to ensure their abstinence once they're discontinued from the medication. Buprenorphine. So studies have shown buprenorphine to be a safe alternative for the use of methadone, primarily because of the lower instance of associated CNS depression or overdose-related deaths during the course of treatment. Suboxone essentially works as a partial mu agonist, meaning that after you get to a certain dosage on the medication, there's a ceiling effect, and any additive medication on top of that doesn't potentiate its effect. Therefore, the risk of respiratory depression and overdose are lower. I kind of give the analogy of if you get behind the wheel of a Ferrari and you mash down the pedal, you hit 200 miles per hour if you're on a full agonist. But if you're on a partial agonist like buprenorphine, you get behind the wheel of that same Ferrari, mash down the pedal, you get to 70 and you're stuck at 70 no matter how hard you're grinding. As mentioned before, buprenorphine and methadone can be used for long-term, short-term detoxification. Studies have shown that buprenorphine and methadone are both equally effective. The only thing is at lower doses, buprenorphine, the retention rates are slightly lower. Here is just showing the two major formulations of buprenorphine or Suboxone, which is a formulation with the combination of buprenorphine and naloxone. One is in the pill form, the other is in the sublingual film. More recently, the FDA in May of 2016 approved Probupine. Probupine is the first implantable buprenorphine. It's about the size of a matchstick. It can be implanted on the inner upper arm in an outpatient simple procedure, and it produces a low level of buprenorphine throughout your system for up to 6 months. This has been created to increase compliance and convenience for patients. The barriers initially to this medication now are the fact that it is minimally invasive, but it is invasive to a certain extent, and B is the cost. Insurance isn't covering it yet, and it costs roughly $5,000 for each implant. This is what it looks like. Like I said, it's about the size of a matchstick, and it's inserted subdermally. Usually, maybe at most takes 1 stitch to put in place. Another medication that we touch base on is naltrexone. Naltrexone is used for people who don't want to be on any agonist therapy. Naltrexone is an opioid antagonist, and it helps people with regards to blocking the effects or the euphoric effects of opiates. It doesn't necessarily address the cravings, so we need that psychosocial support in place. And studies have shown that it's actually more effective in people with issues with alcoholism as opposed to opiate use disorder. Some non-pharmacologic approaches. Study after study after study has shown that involvement in 12-step programs such as Narcotics Anonymous and Alcoholics Anonymous provide greater rates of abstinence. One study by the NIH here shows that among inner city minorities with a long, severe history of either opiate or cocaine use, a high percentage who had continuous attendance in 12-step programs maintained abstinence for a 3-year period. Another approach we take in mental health is utilizing therapy. We utilize motivational interviewing primarily, which is an offshoot of cognitive behavioral therapy. And in this form of therapy, we work with our patients as kind of teammates. We work on their ambivalence to wanting to get abstinent. Hey, what's going on? Why do you like using? Why don't you like using? Where do you see yourself in a few years with yourself using as opposed to not using? And we have them come to the conclusion kind of on their own, hey, I need to stop. And this is powerful because it gives them autonomy and it gives them a sense of they're directing their care. And it allows them to kind of follow through with their care because they feel like they're actively being involved in the decision making. Some things as clinicians, nurses, social workers that we can do when we are dealing with patients who are facing potential relapse is to kind of coach them on relapse prevention techniques. The thing about a craving, or the good thing about a craving, is that it doesn't last forever. Statistically, cravings last anywhere between 15 to 30 minutes. So we coach people up on how to get through those 30 minutes. We kind of tell them, talk about it. Bring it up to someone you're having a craving, hash things out, and kind of figure out if this is the best way to go. Educate people on distracting themselves. Do whatever you need to do. Go for a run, go shoot some hoops, watch TV, put on a movie that you like. Whatever you have to do to wait about 30 minutes and then reassess your situation. Typically by then, the craving is gone and they're able to go on with their day. I know it's easier said than done, but it is helpful. This is also extremely important. People in recovery, remind them to take recovery one day at a time. People typically self-sabotage their recovery when they get overwhelmed, when they think about, hey, how am I going to stay sober for 10 days? How am I going to stay sober for a year? How am I going to stay sober for a 10-year? There's no point, I can't do it. Break down recovery into bite-sized chunks that they can interpret and manage. Relaxation. All of this is stressful, so figuring out ways to relax and educating people on relaxation is important as well. Here, this is another study funded by the NIH, and it assigned people to groups with minimal counseling, standard counseling, and enhanced services in addition to pharmacotherapy, in this case, methadone. And as expected, those in the enhanced services group has significantly less relapse rates. So it's not just medications, but it's the support around them and the therapy that they're getting. Finally, the role of diet in recovery. So diet is important. A lot of people who are using don't care for themselves, don't eat properly, and when they try and recover, they're nutritionally deficient, essentially. Educate them about getting complex carbs, taking vitamin supplementation, amino acids, reducing their caffeine intake, drinking plenty of water to kind of hit the reset button in terms of homeostasis within their body. Educate them about the bad things, avoid processed foods, sugars. A lot of times you see patients munching on Skittles or these other things, and it's kind of substituting one habit for another. Excess amounts of sugars trigger dopamine, and they're looking for like a little bit of something to take the edge off. Eat lean proteins and fibers because it maintains your energy levels throughout the day. You avoid those ebbs and flows in energy, which may make you irritable and more susceptible to use. And finally, eat regular, small meals. Thank you very much.
Thank you, Dr. Joseph. So we really did well on time. How about a big round of applause for our panelists? We have a few minutes left where we can take some questions or comments. Please, if anybody has one, raise your hand and the microphone will come up to you. Lisa?
Excellent presentation, everybody. And my question is for our Attorney General, Mr. Grewal. It's commendable, all the things that you have put into effect. How can we, as healthcare providers, truly partner with you to fight this epidemic right now?
That's a great question. I mean, you know, so much of what we're doing is on the law enforcement side of the house, and we're trying to forge these partnerships with healthcare professionals. I think a lot of it is just the education, because what I found interesting, and Liz Rabine's behind you, we went and talked to residents. And we went to talk to residents at your Mountainside campus, and we did a presentation which touched on a lot of what was spoken about this evening, about the history of heroin, about the history of the epidemic, about how we got here. And we focused more on the culpability of the pharma companies, which we didn't touch on tonight. It was alluded to, and how the corrupting influences that the pharma companies had. One thing I didn't mention in our enforcement piece is we are suing Purdue, we are suing INSYS, we are suing a lot of the pharmaceutical companies. So I think as experienced medical professionals, I think there's an opportunity here to educate those who are coming behind you about how to be responsible in prescribing, how to educate yourselves about this epidemic, so we're not forced, to repeat it again when the next great drug comes out, when they tell us the chance of addiction is less than 1% when they knew it was patently false. So I think just being more responsible, more cognizant of the role of pharma, and I don't want to open up a discussion on the $15 rule or anything else today, and but just be cognizant of the influence that pharma has and how to be responsible and educate yourselves.
Thank you. Anybody else?
I have a question. Thank you so much. My question is on the benzodiazepines. Nothing's talked about with the lorazepam, the Ativan, the Xanax, the Klonopin, that people who have surgery, who maybe need that right after, the IV Ativan works very well. I know we don't want to talk about that, but that should be discussed also, because there are many people that do get addicted to higher doses of the other medications, the benzodiazepines. Thank you so much.
Since not every person who's given a prescription, becomes addicted, should we be looking at a disease before the disease of addiction that we can look at and help prevent this and stem the tide of this along before, because we can't lock these people away. The police can't make this go away, but if we can do this in early childhood and young people and look at this pre-disease disease, this could prevent this over the long run.
No, I think what you're describing is exactly what we want to do. So when I described the journey of someone through their initial exposure to opioids, there's a whole category of things in the prevention side that start really early in life. Start with education, start with having the right social supports and supportive environment for children. Start with treating parents so that their children are not exposed to all of the environmental issues that come with addiction. And so that folks are not going into their parents' medicine cabinets and getting pills to use themselves or sell to others. And so, you know, I just provided a few examples of best practices. The Attorney General came in with all the stuff they're doing on the law enforcement regulatory side. It's really expansive, but you're right. I think it has to start at a young age. And again, that partnership with other departments that have not traditionally been part of this, like the Department of Education, really going across the state government and seeing what we can do is really important.
Thank you. One more question?
Hi, I'm John Kukowski. I'm with Governor McGreevy's program, New Jersey Reentry. Former pharmacist, 3.5 years sober. And, you know, it's, thank you. Thank you. So, you know, with my story, I try to marry the two topics of pharmacy. My license is currently suspended right now, but I work a 12-step program. I just had a quick question. This is for the commissioner. There was a very specific slide where we said, you know, the model that Rhode Island has adopted, you know, prisoners can receive MAT therapy for up to a year, and then underneath it, I saw that they then receive Vivitrol 1 to 2 months after, before their release. But that process of getting somebody from MAT to Vivitrol, what does that process entail? Do you have any information about that? Like, basically, my concern is like during that time they're tapering off the MAT, such as an agonist or a mixed agonist, such as buprenorphine or methadone. What is that process entail? Like, do the prisoners become sick? Is it a hard process? And is the Vivitrol effective after they're released from prison? So.
Yeah, no, it's a good question, and you know, you'd have to go to the study to get their exact protocol. But a point to make, and then I can sort of pass the ball to Dr. Joseph to talk about the risks here, is that they have a comprehensive addiction treatment program with an addiction specialist and with folks who are counseling these folks. And so people are monitored as closely as they are in some of the best outpatient treatment programs that they have in Rhode Island. So this is not cheap. It involves a lot of resources and a strong investment for this population that is very high risk. If you had any other.
With regards to MAT, just speaking generally, when someone is maintained on some sort of agonist therapy and there is an anticipated date of discharge essentially, and you can kind of map out what's going to happen. Typically, when we're taking someone off of high doses of opioid agonists, we want to do a 10 to 20% reduction per week maximum, and kind of monitor their withdrawal symptoms, how they are, and use adjuvant medications to address things such as sleep, anxiety, things of that nature. And with regards to Vivitrol, Vivitrol is effective, but like I said, it's not just the medication, it's the comprehensive team that's in place and the psychosocial services that are there to monitor the patient that will help them get through the situation.
Thank you.
Hi, my question is basically for anybody who wants to answer it. I'm a district student assistance coordinator, so it's my job to deal with the kids who have drug and alcohol and mental health issues. I understand that the opiates are killing people at an alarming rate, but what our main concerns are right now is with the increase of medical marijuana being available and the fact that now the governor is speaking about making it legal, what is going to be done for New Jersey public schools when these kids are coming in the building high and our violence is going up and maybe driving and, God forbid, active shooting? there is so much responsibility on the SAC's responsibility now that when these kids are walking in high and they're already saying, well, miss, you know, it's going to be legal. So what are you going to do for us?
I can take a stab at that first. One thing to make very clear is that the program that we're focusing on and expanding right now is medicinal marijuana. And the governor has asked us as a department to focus on that in the current legal and regulatory framework. So we are following states that have done this right. We essentially took the list of recommendations we got from our panel for diseases that were presented for which marijuana can be effective. We did not accept every disease that was requested. For example, asthma was put forward. It did not make much sense to us to treat asthma with medicinal marijuana. So there was thought into this to make sure that there's likely to be therapeutic benefit. And again, we're focused on expanding access to when a healthcare provider recommends it for a specific set of medical conditions. In terms of the political debate around legalization, the department is not currently involved in that.
And just to follow up on what Sharif said, you know, I think we have to be careful not to send mixed messages to kids. You know, and if there is legalization that's outside of our lanes, that's in your legislators' hands. We are at the Attorney General's office left with enforcing whatever protocol is put into place. But let me just highlight, when we went in to speak to kids in schools, if there's going to be legalization, it's for adults, right? And what we stress is that there are different paths to addiction. And we talk about the common path from a prescription, but the other path that we've seen is somebody saying, you know what, I was never going to be that kid who was going to shoot heroin. I was never going to be that junkie. I was never going to be the kid who used a needle. I was just the weed guy. I was just the marijuana guy. And the point we try to drive home is that it is when you're in that state, your brain is not fully developed yet. When you're in that state, whether you're drunk, same thing with alcohol, right, with them drinking. It's when you're drunk or it's when you're high, when that pill is put in front of you at a party or that opportunity is given to you, you're not able to assess right and wrong or have good decision making. So the message that we've consistently given kids when we're in Bergen County and the presentations that they give is don't try any of these. Don't try any of these because they'll put you on that path. You know, if your mind and you don't have all your faculty, and if your mind is not fully developed, you just have to stay off all this stuff. And so that's the messaging, and I'm hoping whatever the framework is for legalization, if they go down that route, our legislators include in there that money be used for education on avoiding all sorts of addictions, to include opioid addiction, to include the use of marijuana by children.
And just to make one more point in addition to that, I presented studies on statewide looks at how medicinal marijuana has led to less prescription opioid use. There are also studies that show effects on child development that are pretty clear. They're, again, association studies based on surveys of use, et cetera. But yeah, it is clear that when folks' brains are not fully developed, that causes major problems. And so, you know, public health messaging around the risks should we have legalization will be really important.
Governor?
Thank you. By the way, this is a great presentation, and thank you all. Before I ask my question, I just want everybody in the audience to know that the Attorney General, his SAT scores weren't high enough to become a doctor, but he married very well. he married up. But I won't say anything. The poor, county executive is there in that old corduroy jacket, and all I know is the sheriff has got this fancy Bergen County taxpayer thing on. But I'm not saying anything. And also, Balpri, I just want to say you organized a great conference. Thank you. But one of the areas that on treatment per se, as we see, just two questions. I see all these young kids go in for these 28-day wonders, go in and go out, go in and go out, go in and go out. Then they go into prison, then we get them. And I guess I'm frustrated with the fact that I look at other states, and you know them, and I appreciate the reference to Long Island, but best practices. And when you're grappling with fentanyl, the idea of a 28-day program I think is no disrespect, I think it's crazy, if not ludicrous. So one is just, whether it's drug court, whether it's behind the wall, whether it's treatment per se, it's Dr. Candidly, it's your kind of leadership in synthesizing and setting forth a clear course that we need a best practice template. And I just, so many of us are with so many families, and their kids have just been recycled in and out and in and out. And then second, and part and parcel of that is connected to AANA. I don't mean to sound so old-fashioned, but when people come out, that's it. That's the only thing in the community, in addition to IOP. So the first part is like template. And the second part is Hep C. And I applaud what Governor Murphy's, what the administration has done with the Commissioner of Human Services from F2 to FO. But it's just rampant. It's just, it's rampant. It's like every single young person I deal with coming out of prison because of that needle has hepatitis C. And what happens is if it's not addressed behind the wall, candidly, and we try to talk about Vivitrol, but because their viral level is so high, so many physicians that we work with are loath to administer the Vivitrol. They say, all right, we'll do the daily injection, but we won't do the monthly. New York is doing some really exciting things on hepatitis, HCV behind the wall, and I know it's expensive, but at some point in time, I just wanted to make a pitch that we can't just look at addiction, particularly for the reentry population, without wrestling with HCV.
Yeah, and you highlighted, Governor, the fact that the governor's budget is now going to cover these modern drugs for hepatitis C well before cirrhosis and late-stage liver disease, which I think will be really important, and it's accounted for in the budget, and it's something that we're going to push. I think there are also a lot of good ideas out there about extending screening services. And
in New York State Prison, every single prisoner is screened.
Yeah, absolutely.
And we need to do that in New Jersey, so at least we have a baseline of understanding where we're at.
Yeah, and we know for liver disease, the earlier that it's detected, now that we have effective therapies earlier in the process, especially effective ones, that obviously these outcomes will be a lot better.
So unfortunately, our time is over. I know this could go on for hours, but let's give a big round of applause to our panelists. We thank them for coming here. We thank all of you for having this crucial conversation about a healthcare crisis. Thank you and have a good evening.
Right, $10,000.
Hi.